All right. Health communication interventions come in a variety of forms. There are a lot of different things going on, and I wanted to highlight the NLM is really focused on online health information systems, but that's only one little piece of the package. And one of the things that I feel really passionately about is that if we want to do a good job at health promotion, we need to really enrich the entire information environment. We need to have a variety of different complementary, reinforcing and evolving channels of communication, and not to put all our eggs in one basket. So, I start off with the most basic and the oldest and probably the most widely used medium, print. Posters, pamphlets, handouts, magazines, newspapers, and journals. I think this is kind of like the backbone to health promotion, health education, health communication. I'd say 75% or more of the money and efforts put into health education are used for a variety of these. And I think posters, pamphlets, and handouts are the really big ones. That's what they spend a lot of time and money with. What do you think are some of the limitations to focusing so much attention on posters, pamphlets, and handouts?
We tend to gloss over it.
Yeah, there's not a lot of depth, because they're posters. How much can you tell people? They're also not interactive. It's like it's a one-way form of communication. It also gets old very quickly and goes out of date. Also, people don't like to read. We like to read because we're academics, but most people don't like to read, and they get really turned off by those kinds of things. Magazines, newspapers, and journals are different. Those are more depth of information, but our society is becoming less literate and less focused. And when I talk to my students, I ask them how many of them read the newspaper. None of them do. Some of them read the comics, but they don't really. I said, where do you get your news? Most of them get their news from the Jon Stewart show, or from Facebook. They just don't. They don't really pay attention. Of those three, magazines, newspapers, and journals, I think newspapers are the most important of the three. But newspapers are going through a major shift right now. Most people don't read journals. Even academics don't read journals. There's too many of them. How do you keep up with it all? Magazines, are not necessarily handling health information very well. If you look at some of the popular magazines, you see so many contrary messages. We did a recent analysis of women's magazines, some of my students and I, and we found out that in the same issue they were promoting cooking and eating really fattening foods and dieting at the same time in different, dueling articles, and confusing people tremendously. So, personal interactions, presentations, health education, counseling, support groups, consultation. This is a really important form of health education. The data suggests that people want their health education presented interpersonally, primarily by their primary care physicians. And they trust the primary care physician. They want the physician to tell them what to do and how to do it. But the amount of time, face time, people spend with their physicians is really minimal. Some people not even once a year. And even when people go to the doctor, they end up spending most of the time getting there, waiting in the waiting room, being examined by the nurse, and maybe very like 5% of the time for the visit with the physician. And during that time, the physician's not really providing a lot of health education. They're doing a lot of instrumental and routine things. So that's been a real problem. Not many people, believe it or not, actually participate in support groups. Far fewer that need that. We need to provide more ways of providing counseling and education and support through interpersonal communication. So one of my goals in my endeavors to develop health communication interventions is to try to build in wherever I can interpersonal mechanisms. And it's not tremendously popular. We love media, we love tools, we love programs, but I really think that we need to build in human interaction. And sometimes that can be delivered via media. And I think that's a way of kind of breaking down some of the problems. But I really think that human interaction is critically important. On the other hand, there's some real limitations to the human interaction. So let me open it up to you. What do you think some of the problems with putting your eggs in the personal interaction basket?
It limits the reach because you have to have.
Doesn't have a broad reach unless you do it over a mediated channel.
Right.
And even then, the exposure is not tremendously great. And we don't love to look at talking heads. It's very hard to control what people say. And so you may set up these interpersonal interactions and people say things that you don't want them to say that make things worse. They're very short-lived in terms of their influence. It's kind of in one ear, out the other ear. It seems to make sense and influence you at the moment. But because it's a one-shot encounter, unless you build in reinforcement, the influence is not as great. One of the real advantages is that it is dramatic. Personally, especially face-to-face, it's hard to ignore. You can use it as a way of building relationships. There are opportunities for interaction and feedback. So I think there's some real strengths and real weaknesses, but it's difficult to manage. And it's also expensive. If you want to do an intervention that involves having doctors talking to patients, you have to figure out how are you going to pay for that, because the doctor's time is very valuable. And even if you're not having doctors or using paraprofessionals, their time is expensive as well. Entertainment media, such as television, film, and radio, one of my favorite channels. We all want to be entertained. Let's see something that moves us, that makes us laugh, that makes us cry. Something that really is engrossing, that moves us and makes us think and imagine and vicariously experience different situations and model our behavior after people who are able to confront serious health issues and overcome them. But there's some real big problems with entertainment media. So let me open it up to you. What do you think the problems are with entertainment media?
I think when they involve like the creative persons, it's really difficult to convince or control the message.
Right. Their goal is not to promote health, unfortunately. Their goal is to make money. And so they want market share, they want advertising, and so unless you can convince them that doing a good job of covering important health issues will garner a good audience and generate advertising and other kinds of ratings, you're going to have a really hard time getting them. Not only that, the producers, directors, and writers don't really have a lot of good health information. I don't know if you realize this, but they're not health experts, and they often will make stories that don't make sense. If you look at any of the health shows, within a half an hour or a 45-minute show, major health problems are solved, magically, and then you don't really understand how things work. A lot of the shows are tremendously misleading. Some of the most popular shows, like House, which is a really interesting, fun show, portrays health communication in a very negative way. House is not a really good communicator. He doesn't really collaborate with his patients very well. He dominates them. He manipulates them. He's, and all of a sudden, sometime during the show, some magical thing happens, and boom, he's got the answer. So basically, he says you can be a jerk and be mean to people, and not really, care about them, and you still can solve problems. So it's not a very good message, and not a very good model for encouraging people to be really caring and therapeutic communicators. The good things about the entertainment media is that the great exposure, and it's not hitting people over the head. A lot of these other methods, the print and even the personal interactions, are so directive and prescriptive that they turn people off. And so I think it's the more subliminal part of the entertainment, where you embed the message within something engrossing and entertaining, and not just say do this, but letting people to figure out these are things that people have done, and these are things that I can do, is very powerful. So one of the things that it suggests to me is that we really need to learn how to work collaboratively with media producers. And that's one of the things that I've been working on really pretty hard for the last decade or more, is to make friends in the media industry, learn how to work with folks who are movie producers and writers and directors and actors. A lot of actors want to be producers and directors and writers. I work with a lot of professional organizations like the Entertainment Industries Council, Hollywood Health and Society, to try to, the Writers Guild, to try and help promote better coverage of health issues. And we've been in EIC, the Entertainment Industries Council, and I've been doing a series of meetings. They call them Picture This meetings, where we bring together in different parts of the country local media producers, news people, television, radio, and then in New York and also in Hollywood we do film people. We bring in advocates and experts for different health issues like diabetes or heart disease or cancer or mental health issues. And then we bring in experts like social scientists like me, and we all work together to try and brainstorm better ways of covering these issues and come up with action plans. And then I've been evaluating these programs. I did a couple of evaluations, I think 5 of them, 5 different cities, and found out that they actually did change the media environment, that we increased coverage on these specific health issues afterwards. So we did an evaluation of it. Digital media, this is the new frontier. And digital media, I think, is where most of the health information is. And this is where the National Library of Medicine is really interested and excited because they see this as where health information is going. I'm a little bit more tempered. I mean, I'm excited about digital media and I love digital media, but I don't want to see it as a replacement for these other forms of communication. I want to see it as a supplement and a complement. I want to see how we can articulate the use of digital media, like websites, computer portals, webinars, telehealth, mHealth, tailored information systems, online support groups, telemedicine monitoring systems, interactive digital human agents. These are all, and the environment is changing and evolving really rapidly. So what are some of the advantages that you would see of a digital intervention system?
Reach, access.
Yeah, you have broad reach. It's one of these media that can be both interpersonal and mass at the same time. There's opportunities for interaction. There's ways of integrating entertainment where you can do all kinds of video and cartoons, and you can be very vivid. It's easy to update because you can change it and evolve it over time. It's dramatic. It's exciting. Using tailored information systems, you can personalize it to the individual. So, what's the downside?
Access.
Access, particularly with marginalized populations. Do they have the equipment? Do they have the knowledge? Do they have the media literacy to be able to utilize the equipment and utilize the information? And then the issue is design. We're so enamored with the channel that we don't realize that we need to really come up with a really good set of messages and design issues for using on them. And a lot of the websites are tremendously clunky, dull, complicated, misleading, difficult to navigate. Webinars can be deadly. I can't stay awake for more than 15 minutes with a webinar because it's like, I don't know, maybe I have a limited attention span, but I need more stimulation than that. Typically when I'm doing webinars, I'm like, multitasking. I've written a lot of good articles during webinars, but I didn't get a lot out of what was going on there. I think telehealth has tremendous potential. for reaching people where they live and when they need information. I love the idea of mobile health, of getting information to people when they're on the move at the right time and place. But there's some real difficulties getting, and then there's also the problem with information overload, that there's so much digital information, and it's difficult for people to discriminate which information is most relevant for them, which information is most appropriate, and so there's a lot of mispersonal diagnosis going on. I know a lot of people, when they read things, they hear about a new disease, they get it, because they feel that they recognize those symptoms themselves. It's almost like they're forcing themselves to parrot those symptoms. And then there are also a lot of opportunists out there who are trying to make a buck to vulnerable people by selling them products and services online that they don't need, that are no good. And there are lots of really terrible quacks, particularly in areas like inoperable cancer and other deadly diseases. Are selling products and services that are making people sicker. So there's a lot of big issues. So it seems to me that we need to do a good job of figuring out how to utilize all these channels. So how well do these intervention programs work? And so at the time when I was doing this, we had all these health promotion experts in the audience. We had about 100 of them sitting there. I said, well, how well are your programs working? And most of them had no idea whether it was working or not, or had a glimpse, weren't really sure. So what influences do health communication programs have? What kind of outcomes are you achieving? It's very important to know that, and often they don't know that. A lot of times, the push is to put on the show, to get up the program, to get it out, and not on figuring out what difference it makes. Is anyone paying attention to these programs? And in some of the evaluations I've done, the people who are paying the most attention are the media producers themselves. It's kind of like us with our journals, Who's reading your work? I'm reading my work. Who's citing you? I cite myself, How do diverse audiences respond to these programs? And so what happens a lot of times, the programs are designed to help at-risk populations, diverse populations, but those are not the people that are paying attention. And a lot of the analysis of the use of online information, for example, shows that generally well-educated, affluent, middle-aged women are the ones who are, getting the health information. That good news is that they're helping other people, but bad news is that the people who really are desperately in need of the information, the poor, the underserved, the seriously ill, the uneducated, marginalized people are generally not paying a lot of attention to most of these programs and don't have access to kind of cut out of the system. They have serious problems with information gap. So what's being learned from these programs? What are people learning and what are they doing? Are there any unintended influences, including boomerang and iatrogenic negative effects? There's a big literature that's developing on boomerang effects from health promotion, that a lot of times they end up having very opposite influences than intended. Why do some health communication programs appear to work, and what parts work best? So you can refine them. Can we do this in the most expeditious way? What are health intervention programs intended to do? And this is, it goes back to some of the things we were talking about earlier about needs analysis and clarification of goals. What do you want to accomplish with specific health communication programs? And a lot of times I don't think that the health promoters think through what they really want to accomplish, and they're looking at fairly superficial outcomes rather than the bigger issues, not really dealing with the underlying problems. I think so. Some self-reflection is really critically important. Which audiences do we want to reach and influence? And as we talked about earlier, there's a move to hit the broadest audience with the smallest message, which basically diminishes the impact of many of these programs. What do we want these audiences to do, and can they do it? Do we have measurable goals and outcomes in mind? I asked some of these media producers to give me a list of what their measurable goals are, and they looked at me like I was from outer space. They never thought about that. They didn't really have any measurements in mind. They didn't have any baseline data. They weren't tracking any outcomes. And part of that is because the agencies were not providing them with money to do that. They weren't encouraging them to do that. They would just encourage them to get programs out and to keep feeding information up on their website. Is there an established baseline? Is there a strategy for making our programs effective? And strategy is a euphemism for theory. I didn't want to use theory with this group because then they glaze over. But why are you doing what you're doing, and what strategy are you using to reach people? Our program is sensitive to unique audiences, including their cultures, needs, literacy levels, and expectations. If you look over this list, it's basically what kind of turned around from what I wanted to do with audience analysis and needs analysis. These are all the issues that we're trying to identify. And the scary thing is that most of these people who are spending millions of dollars of taxpayer money every year on health promotion are not doing any of these things. They've got tremendously good intentions. They really want to help people, but they don't have much data to guide what they're doing. And I think if you don't have good data, you're really, spinning your wheels and wasting your money, and sometimes making things a lot worse. And so it's a real big problem. So many programs are designed with good intention but limited data due to common erroneous logics. And these are the things I've learned from talking to these government and health promotion gurus. These are what they think. If you build it, they will come. We'll just do it, and it'll work. Okay? If we just put out the pamphlets or the posters, it's going to work. Trust me. We've done this before. We always do this. It works really well. Don't hassle me. We know we do. We've got a machine here. We've got it all set up. We just can kind of like crunch it through, and it's easy. It's expeditious. It's efficient. It's not very expensive, and so they keep doing the same things. And they don't know if anybody comes or not. There's a rush to action. And there's a push, particularly because a lot of these agencies are very reactive, and they're dealing with a problem. Mortality's up, infections are spreading. Let's go, 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 go. Get it out, get it out, get it out. And sometimes they're in competition with other organizations, corporations, the tobacco industry, the alcohol industry, the food industry, other jurisdictions, and they're trying to beat them out and get the information out before the other people. So there's a real big rush, and they don't want to take the time to think things through and to gather data. This is the way it's always been done around here, and it's been working just fine. Thank you very much. I like our program. It works for me. Don't bother me. Evaluation research is not in our budget, and this is probably the one I hear the most. We'd love to do that. Sounds like a great idea. We can't afford it. We have no money. Thank you very much. Data gathering is too time consuming. We don't really have time for that, and too expensive. Data are difficult to translate and implement, and because people are not particularly good at research, they don't know what to do with that information. But this is a tremendous opportunity for scholars like you and me to be partners with these agencies and to help them gather data. And I think that there's an opportunity, huge opportunity for health communication scholars to work with government agencies, both locally, nationally, and internationally, to guide their use of data. And I'm doing this like crazy. I can't do it all. I need help. There's tons of opportunities. And I think many of you can be doing this as well, as advisors and consultants, and sometimes as in-house evaluation experts. In fact, a number of my graduate students are working for different agencies now, basically doing evaluation research for them. Research is a waste of time and money. That really hurts, doesn't it? People have already made their mind up about that. It's probably a waste of time and money because they're not doing it very well. They don't know how to interpret the data, and they haven't been able to implement it very well. So there's a number of challenges. These are some little things, little illustrations I gave to these folks. They like these. This is a nutrition label for a chili and beans can, and it looks pretty good, you know. But if you know if you're a heart patient or you're diabetic and you need to be on a salt-free diet, you notice that there's 1,010 milligrams of sodium in just one cup. That means there's 2,020 milligrams of sodium in that can. And sometimes people will eat the can for their lunch, which is probably about 20 times what they need to have in a day. But people don't know that because they don't know what sodium is. How many times do people say, "Pass the sodium, please"? You know. And so this is a communication problem. This is a consent form that we made a copy of. You can't read it, but it says here, "I have discussed the likelihood of major risk or complications of this procedure, if applicable, but not limited to, infection, hemorrhage, loss of limb." You know, is this the way people talk? People can understand that they're going to gloss over. And so what ends up happening most often than not is that the doctor or the nurse more often will give the patient this form and say, "Read this over and sign." And people will say, "Okay, they'll just sign it." Then even I do that because I don't have the time and patience to read it, and I'm just assuming they're not going to kill me.
But we
You know?
should, right? I mean, not limited to infection, hemorrhage, loss of a limb, paralysis.
Medicine ads, right?
I feel like I'm reading a prescription pamphlet that comes in a bottle. You know those flyers that we never read anyway.
But the truth of it is that this is not really designed to communicate.
No.
It's designed to cover the butts of the people who are doing this work. It's basically a legal liability and regulation issue. But you know that they have the legal and moral demand to provide informed consent. Every time they do a procedure, healthcare providers are mandated that they have to provide you with full, clear information and alternatives so that you can make a reasoned choice. But that doesn't happen. This is informed consent in everyday healthcare practice. All right, take a teaspoon. A teaspoon is a very funny thing, depending on the size of the spoon that you use. You can over-medicate yourself and your children very quickly with the wrong kind of spoon. So there's need research. We need data to enhance communication. Hey Jeff. So good data are like turning on the lights. This is what this is my persuasive rap to try and encourage people to do evaluation. You can see what you're doing. Try and do some kind of intricate procedure in the dark. You just can't do it. It's difficult to get it right the first time. Good data allows us to assess and refine programs over time. There's this kind of a optimistic bias that a lot of health promoters and healthcare providers have, that they're going to come up with the optimal solution right off the bat. We're going to make the diagnosis, we're going to give you the prescription, we're going to put together the program, everybody's going to buy it, they're going to change their behaviors, life is good, we move on to the next thing. But that almost never happens. The biggest thing is that you get your foot in the door, you find out what the response is, and you refine over time. And if you have a good healthcare provider, that's what they're doing. They're giving their best shot at what they think will help you, and then they're monitoring your response and adapting and adjusting, particularly if it's a complicated issue. This goes back to the Weich's model and requisite variety. That this is, the more complicated the issue, the more we need to adapt and evolve and get information to make sure that we have it right. But there's this kind of this oversimplistic notion that we're just going to do it and it's going to work and we're moving on, gleefully jumping from stone to stone and not really thinking about what we're doing. People respond differently to healthcare systems, to medications, to health information, to messages. And if you're just going to do one basic strategy, you're going to lose the majority of people. And even the people that you get that works with now are evolving and changing, and it's not gonna continue working. So you need constantly getting feedback and information so you can refine. This is kind of like a message about communication competence. When you're working with people, you're interacting with people, you can't interact with them exactly the same way every day. You've got to adapt, you've got to adjust as your relationship builds, as they have different needs, have the different issues. You know, one day they're happy and you can interact with them in a certain way. Another day they're unhappy, they're sad, they're scared. You can't give them the same message you gave them when they were happy. It doesn't make sense. It doesn't fit their situation. And it's the same thing with health promotion. So we got to figure out how we're adapting to the unique audiences. Data gathering can also connect us to key audiences, and it's been one of the major strategies I've been using to develop a participative approach to healthcare and health promotion. Because I meet the people, I find out what their issues are, I let them know that I'm here to help them. You know, a lot of times there are people who are really upset because they are diagnosed with a serious problem. They don't really know what the right thing to do is. They don't feel that they're getting a lot of respect from the healthcare system. They don't feel like they're getting enough support. They're worried about the way they're being treated or the way their loved ones are being treated, and they're very uptight about it. And here I come saying, hey, I'm here to help you. I want to kind of unpack this for you and figure out what the best thing to do and try and improve this system. You make friends really quickly that way. It's amazing during my initial interviews, because I always take this approach, what can I do to help you? How can I address the issues that you're having with this problem? And then you build friends, and then you build partnerships. And so using this kind of data analysis is a way of connecting you in a very direct way with your audiences, which is, and you start to realize that health promotion and intervention is basically a relational process, that the health promoters are working interdependently with the audiences they're trying to serve. And then they have a shared vested interest, and they also can help each other in many different ways. And the truth is during the process, it starts off where I'm really running the show at the beginning and setting it up, and as we move forward, I'm investing more and more control to my audience. Towards the end of the project, they're basically running it, and I'm advising them. So maybe it starts off with I'm in control 90% and they're 10%, and at the end they're in control 90% and I'm 10%. Eventually, I'm out of the picture. It's their baby, their show. Maybe I'll hear from them once every couple of years, but that's good, and and it's something that's been institutionalized. But if you don't make that connection with the audience, that transference, that translation is never going to happen. And so if nothing else, evaluation research is at least one way of connecting you in a very direct way to your audience. So you learn about them and you connect with them and you invest in them. And then most of these agencies, Jeff, this is a presentation I had done at National Library of Medicine about 3 or 4 months ago to a group of NIH health promotion people. So I'm trying to convince them that they need to do evaluation research. So this is my persuasion for them. And then this is really one that hit home with them, because many of them wanted to continue getting funding and support and to get more influence within their agency. And if they had good evaluation data, they were able to demonstrate to their bosses, to their funding agencies, to Congress, that the work they were doing was important and worth investment. Good data can justify major investments. I think maybe of all the things I said, that was the one that hit home with these people the most, because a lot of them felt like they didn't have adequate budget, they didn't have adequate staff. They were confronting big health issues like curtailing the spread of AIDS across the United States with a very limited budget, without a lot of investment, and they needed more investment. So what is evaluation research exactly? It's a form of disciplined inquiry, basically, rigorous research involving careful, planned, rigorous study to understand program influences and potential challenges to achieving program goals. Carefully planned and well-conducted evaluation research can provide valid, accurate, results for guiding program development, implementation, refinement, and sustainability. Evaluation research involves the use of multiple methods, such as surveys, textual analyses, experiments, and ethnography. Most of the folks I talked to didn't really understand most of that, but I kind of opened that up, and then the rest of the presentation, try to explain what I mean. So validity was the issue that most of these people really had not thought about at all. And I wanted to explain to them about how they could build valid information systems. Internal validity concerns the accuracy of conclusions drawn from a particular study.
Gary, can you tell us the background of these people?
Yeah, they were basically program officers and directors of different agencies for NIH and Department of Health and Human Services that were running different programs dealing with a whole range of diabetes, heart disease, cancer, infectious diseases, trauma, traffic.
Would you say they had like a project manager mindset, sort of like a
Most of them had like a master's level training. Some of them had doctoral training. Some of them were MDs, a lot of MDs. But they weren't really researchers. They didn't really do, but they were given the responsibility. Most of them were running websites. At NIH and Health and Human Services, the majority of health promotion is feeding their websites. And then also pamphlets and posters.
Yeah, because I'm trying to get a sense of how their brain works. I mean, we're researchers, and I mean, these things are like, you gotta make sure that stuff works. And then you're talking about these people who have the purse strings and make the decisions. I'm trying to get an understanding of, like, if they're MDs, do they see, here's a disease, here's the diagnosis.
A lot of the people were MDs who didn't practice anymore. I'd say that at least half of people with MD degrees don't deliver medicine. They use that as an entree to get an administrative position. And so they were basically MDs who were in charge of health education. All these people were health educators. External validity, I wanted them to know that not only do they need to be accurate, but also you wanted to be able to show that this kind of program will work with other audiences, or to what extent it will work. How can you generalize the conclusions and findings? So why is validity important? Poorly conducted evaluation research is worse than no evaluation research at all, because it provides you with misleading information. Garbage in, garbage out. Evaluation researchers should carefully plan their studies to produce findings that can be trusted and generalized. Evaluation research findings should always take into consideration the limitations of the research, so they had to know how far they can push it before applying these findings. That's one of the reasons I recommended to them and to you to utilize multiple methods to help offset limitations with some methods with the strengths of others, and also to provide a richer, broader, deeper data set to base your interventions on. I've told you this many times because I feel very strongly about this, that I really want to make sure that I have very good evidence for any kind of major change I'm going to recommend, because I really don't want to screw things up and make things worse. Promoting internal validity. So the three basic ways that in the research literature we do: designing the research and operationalizing variables so that they're clearly understandable and they are valid and reliable. And I explain to them what that means. Making sure that you do research with participants that represent a group, and you take into account their biases, history, selection, and any demand effects. And then make sure that you, as a researcher, don't over-influence the findings, because the bad thing about this evaluation research by the program managers is that they've got a vested interest. They want to demonstrate to their bosses that they're doing a good job and that it's working, and so they can fudge the results. Maybe that's one of the good things about them bringing people in like me to do evaluation research. One of the things I was thinking that they could do is, in a lot of these agencies, have a separate evaluation research component. But I think there's a huge opportunity, as I was saying earlier, for for many of you to serve as advisors and consultants to health promotion agencies to do this kind of work. Promoting external validity. The way you sample, make sure it's representative, making sure that the kinds of activities that you're engaging in, the way you're testing it, is what they're going to experience in the real world, and then replicating to do it over with different audiences in different times to see if you get similar results. So, I wanted to break them down to both formative and summative evaluation research. So how do you do formative programs for refining? How do you assess the need for programs? When I talk about formative, I'm talking about both from the setup and the design through the implementation, all the way through and following it through. So it's not a one-shot process, it's a multi-step process. It starts with basically identifying what the issues are, needs analysis, identifying and segmenting key audiences, which is the beginning of audience analysis. Who are you trying to serve and what are the different groups and how do you break them up so in ways that make sense. Gathering full data from audiences about what their experiences, what their needs are, what their orientation is. Once you've done that and you're starting to develop messages, testing those messages as we were talking about yesterday through message testing and usability testing. Field testing program implementation in key settings to see whether it works and whether the system is responsive to the kinds of programs that you're designing. Tracking user responses over time to see, sometimes there's an initial kind of a honeymoon effect where people will accept it and then it'll taper over time. Sometimes it's the opposite. People ignore it and then eventually they catch on. And then sometimes good effects end up tapering off. You need to keep tracking it so you know how to change programs. And then generate user recommendations for revision. This is the feedback mechanism issue that I've been harping on. I really think that this is a critical factor and something that they can do very easily by the design of programs. And whenever I design communication interventions, I always try and build in feedback mechanisms, even it's as simple as suggestions, questions, feedback loops, surveys. But if you do it early on and it's built into the system, it's much better than going back later on. Especially if it's easy for them to do and there's not a demand effect. I worry sometimes when they do survey research for evaluations that people want to show that they're doing the right thing and they're following direction. I worry about the accuracy of that information. So you can track responses to refine program features as you're evolving. So the evaluation research is an ongoing piece of the entire health promotion process. Summative evaluation, and the program people were more familiar with summative evaluation because they were asked to come up with reports to the bosses to say whether or not they were achieving their goals. But more often than not, the summative evaluation was very superficial. It had to do with things like how many web hits they were getting on their website. And web hits is a really gross, broad measure. And it can mean a lot of different things. It can mean that people got there by accident. They spent a lot of time there because they couldn't find what they were getting. It doesn't really tell you what happened while they were there, or whether it made sense or not. So assess patterns of program use. Assess overall user satisfaction with the program. Evaluate message exposure and retention. Track changes in key outcome variables, and this is really a critical one. Learning, health behavior, service utilization, health status, which means that you need to have baseline data on all of these issues that you can track over time. Do economic analysis of costs and benefits of programs, and this is a really powerful one for administrators.
Sorry if you've covered this. Did you find that, a lot of times with the summative evaluation, they're often bad, it seems, because it links back to really, really bad goals in the beginning. You have a lot of goals that are, we will deliver this program, rather than sort of
Right.
some,
Exactly.
meaningful thing.
And that's what they're measuring. They're measuring whether or not the program
was just delivered.
look, we've got a website.
Yeah. rather
Is it
than-
good? I don't know, but it's up.
Did they get that, or were they as guilty of that still?
Well, they were arguing with me that they don't have the resources to do this. Since they really wanted to continue getting investment, they wanted promotions, they wanted to achieve their goals.
Because I think people, when you're writing goals, it's like, we will move the needle from this measurable point to that measurable point. But, I mean, just yesterday, we got a grant, and I don't know how we got it, but the measured goals were like, we will deliver this program. And I wasn't as involved as maybe I should have been. And I went back and I looked at the goals and said, we're going to deliver this program. That's a vehicle. That's not a deliverable.
And maybe the program will make things worse, you know?
Exactly.
Identify best program strategies and features so that if you're going to move forward and build upon this, then you can try and improve in the future. Then figure out how you can sustain the best features of programs. And a lot of times there was no concern about that. And because of that, there's a lot of programs that are very short-lived that don't go very far. And then build support for program institutionalization. The importance of audience analysis and evaluation research. Obviously, we've talked a lot about this over the week, but I just wanted to, hit it again. It's a prerequisite to creating, refining programs that are responsive to unique characteristics of different audiences. Programs based on rigorous audience analysis data are likely to be personally relevant, attended to, comprehended, considered, and accepted by those audiences. And then audience analysis is not an option, it's a necessity. It's got to happen. These are the kinds of data that they should be thinking about. Basic demographic issues that will help them segment their audiences. Current and past related health behaviors. Communication characteristics, and this is something that's not really on the radar at all. So they're not really sure whether or not the media and the channels and the sources they're using are appropriate. So, this is kind of a new thing. To figure out, what are the practices and what are the preferences and what are the capabilities and competencies of these audiences so that you can make sure that the materials sing to them.
Especially language specific, like immigrant groups and their use of, the mainstream media versus another local.
And in the U.S., which is a pretty diverse country, almost all of the health promotion materials are in English. And a lot of the immigrant populations who have tremendous problems don't understand at all. That's been really the biggest issue in the research I've been doing with Korean American immigrants, is that the older first generation Korean Americans don't speak English, don't read English, and they don't have access to any of the information. And the Korean media that they're reading don't provide that information. A lot of the media they're reading is from South Korea.
Mm-hmm.
And so it's not telling them anything about local health issues or where to get help or screening. Knowledge, attitudes, values, and emotions, particularly related to the health issues that you're dealing with. Cultural habits and preferences. Effective motivators, what are the things that are likely to move people? And then to check that over time because it's going to change. And barriers to behavior change. So these are the things I wanted them to start learning about. And all of these things, the most common was probably the demographic analysis. And even then, that was not very strong. So two primary approaches to collecting audience analysis data. The quick and dirty approach, which a lot of them wanted to do because they had no money, was to look at existing data sets. And most of them had access to all kinds of infographic information, and even psychographic information through Nexus Lexis and all kinds of different programs. They also had their own libraries and librarians, and they could look at past studies and research. And since these agencies have been dealing with similar populations over time, they had kind of a track record of what was happening. They had all kinds of epidemiological data. The problem was that the people who were running the programs we're not really good at reading and understanding and utilizing those data. And so you need a lot of help in trying to translate it. And one of the things that I've been doing is I've been placing a lot of my graduate students as interns, and then also getting them jobs with these agencies to do this work for them because they have that background. And I think that there's a huge role for communication scholars to do that, to help them use data sets and understand how to do it. The problem is that all these data sets are old. You know, they may be fairly recent, but they're not current. It takes time for them to get published, they're out there, and sometimes they're tremendously misleading. There also has real limitations. A lot of the survey research is done in English with fairly high-level language, and basically is surveying the most well-socialized, well-educated, and affluent members of any of these communities who have minimal problems, and underestimates the issues and doesn't really identify the key things that they need to learn. So existing data sets, you need to take with a caveat.
So actually, I was thinking about that in your hints. The demographic variable that you have, is it, one of my pet peeves is Asian
Right.
as a demographic
Exactly.
variable, which covers how many dozens of cultures.
We also have Hispanic,
Oh, yeah, okay. That's-
which can be Cuban,
Right.
could be,
South
Mexican, could
American,
be,
Spanish.
yeah.
Is
Spain.
Spain broken out by, how is, do you know the demographic
not.
for Asian?
It's not, Asian is everything,
Yeah.
Indian,
Right.
it's Chinese,
North
Japanese,
Asian, Southeast Asian.
Pakistani,
Okay.
it's, the assumption that these audiences are the same is ridiculous. In fact, that's the reason why
Okay.
I've been doing a kind of this cottage industry of translating into Chinese and Vietnamese and Korean, and doing the work with different audiences. And we've been finding that the data are really quite different.
It's just still mind-boggling.
It's mind-boggling.
To think that it's a variable,
Yes, but and that brings me, Rubberwood Johnson, and we'll have to talk about this. But there might be actually an opportunity for it. But they have their scholars, their minority scholars, and they're begging people who are both within the first 7 years of their PhD and then mid-career, which is 10 years, to do secondary data analysis of an existing, and this is like low-hanging fruit. And I'm
Yeah.
thinking if you want hints work done, even just on breaking out sort of the Asian demographic, I think there's funding from Robert Wood Johnson for it.
Well, the problem is that the secondary analysis of
Yeah.
hints is not good enough
Ah.
because it's already mushy.
Yeah.
They've already lumped all these people together. So what you need to do is you need to kind of,
Primary.
you take it and say, okay, now this is what we found out about the whole
Right.
group. Let's break it down by the different subgroups
Yeah.
and study them individually.
Unfortunately, they're kind of not funding you to go collect data. So
Well, that's one of the things I've been trying to push them at NCI to put out a program announcement for supplemental hints-related studies.
Okay.
Because what's happened is they've encouraged a huge population. We have like 150 scholars who are doing secondary analysis of hints
Oh.
research all over the world. And they do hints data users meetings. There's one being done this month right now. And they're basically, expanding on the errors that already exist within the data set and not improving upon them. What they do is they're kind of like pulling out variables. I think it's a good thing to do, refining the findings, but it's not nearly enough. And that's true of any large national survey, that there's not going to be the specificity within geographic area, within subject group that needs to happen. So that's the cheap and dirty way, and a lot of them like that because then they don't have to leave their offices, they don't have to talk to real people, they can just look at paper. Although I don't feel that they're going to understand the data to be able to use it very well. And then the other one is to collect new data, which is what I recommend that they do, so it's responsive to their unique audiences, because it's in real time, they can get in-depth information. And I talk about focus groups, surveys, interviews, analyzing key audience documents, gathering archival data as ways that they can look at specific audiences. Key factors for effective collection and use of audience analysis data. You make sure that the audience analysis guides program development. It's not just you're checking off, well, yeah, we did that, but now we're going to do what we wanted to do. Sometimes they have the programs planned ahead of time, or it's based on an existing program, and they'll do the audience analysis, but they won't change the program. It's crazy. It's a crazy situation. Should assess program performance across different audiences over time. Interviews, focus group surveys, textual analysis, observations are all good tools. Interviews and focus group data can guide survey design and also elaborate on survey findings so that you kind of nesting methods together, so they fit together in a kind of a synergistic way. Surveys provide good audience characteristics. Interviews, focus groups are best for generating new ideas because you can push people, you can probe, you can ask them questions, you can get them thinking. I particularly like focus groups for coming up with new ideas, and I've used that a lot. Build our evaluation research into every communication program. Examine available sources of audience analysis data. Identify natural sources. I'm a real big believer in unobtrusive measures. I worry that we depend too much on self-report data from people who have demand effects to tell you that they're doing the right thing. How much alcohol do you drink? Oh no, I never drink. You know, and then they, you do look at what they have, in their home, and there's all kinds of alcohol. And so it's did you stop smoking? Yes, I did. Did you start smoking? Yes, I did.
Yes, between cigarettes, I stopped.
Yes, I'm really good at quitting. I've done it a billion times. So natural sources of medical billing records, I think, are great. One of the real boons to the electronic medical record is that there's a treasure trove of data if you can get access to it. I've been very lucky that I've been working with healthcare systems like the Veterans Health Administration, where I can get access to that information, and I use it in a lot of my interventions to identify what kinds of issues and problems people have as a way of tracking changes over time, as a way of informing healthcare providers about key issues and functions and activities, and also for triggering activities, so that when you identify through these natural data sets that there are problems, it triggers a set of events to respond to that in a very proactive way, rather than waiting for people to show up in the emergency room or show up dead. You've got a way of dealing with those issues and promoting health early on, or finding out when people aren't understanding. For example, in the work I'm doing with medication adherence, there's a way of tracking whether people actually purchase and pick up their prescriptions. And you ask people if they're taking the medication, say, oh yeah. Well, how come you haven't picked it up in 6 months? How are you taking it? They're not telling you the truth. And it also can automatically indicate, be fed back to the doctor, maybe there's a need to do some counseling here. Maybe there's some issues and concerns that people have. So you can use those data to try to improve delivery of health information. Implement built-in user response mechanisms and feedback mechanisms that I talked about already. Establish baseline benchmarks for later comparisons. Conduct usability tests of interventions to see whether or not people actually know how to use the programs that you're designing. And work with audience members themselves to design programs that meet their needs through a user-centered design process. And then test and refine messages and programs over time. So I think this has got to be part of everything they're doing. There are a number of concerns I have about the way that evaluation research is done, and I don't think it's always done very well. I think that we often depend on one point in time cross-sectional data. Part of that is a funding issue. Part of it is a lack of recognition that this is an emergent, evolving process. So I think whenever we design evaluation, we need to think about collecting similar data in several points in time so we can track changes. If you don't do that, you don't really know whether it works. It always amazes me that people do summative evaluation with one data collection point. How do you know that that's better than where you started? How do you know that you made a difference? And it's also impossible to do refinements if you're not tracking over time. a limited validity of self-report data, and it's, when people do evaluation, there's often surveys. And I don't think that provides strong enough data. A lot of times, particularly the use of questionnaires, there's very limited depth to the response. So you may know how they respond to things, but not why, or what's going on, or what the motivations are. Too much shallow data, number of web hits is an example. Use of weak measures and tangential variables. What happens a lot of times is the law of the hammer, that people know one instrument, they know one tool, they use it, they don't care whether or not it makes any sense or fits what they're doing, and it doesn't tell them what they need to know. And I worry a lot about many of our scales. They may be psychometrically reliable, but I don't think they're often very valid. I think that a lot of the scales, I don't know whether or not they tell us about what self-efficacy is or not. And I'd like to supplement that with more information about what people are doing and how they're feeling and what they think they can do. Sometimes a 2, 3, 4, even a 10-item scale is not really telling us much about the individual. Poor data reduction, which means that they collect all these data and they don't know what to do with it. And they don't know whether it makes sense. And that was one of the things that people told me, that research is too complicated and you can't use it. It's because they don't know how to make sense of it. And they can't break it down very well, and they need help doing that. So people who are good at statistical analysis and making sense of the data and teasing out variables and breaking things down can really help them. In some sense, I think that these agencies have to have some well-trained researchers working with them, either within the organization or as advisors. A failure to apply data to improving programs, which we mentioned already, is that they gather the data and then they don't use it, partly because they don't understand what it means, partly because they don't want to change the program, partly because they don't have the money to change the program. And so there's all this data showing that it's not working, and they don't care. This is what happened with the National Youth Anti-Drug Abuse Program. They knew that the commercials were actually encouraging a lot of at-risk kids to take drugs, but they'd already paid for the program that was up there. They liked the way it looked, so they kept showing it, making things worse. It was just like, what? What are you doing? Lack of hard outcome and economic data. A lot of times we'll look at satisfaction issues, which are important, but I really think that the key hard data about, are people actually getting screened? Is their level of morbidity decreasing? Are they spending less money? Are they being in the in the emergency room less? Or is the system saving money by this intervention? Are really important data points. And unrepresentative samples. A lot of times messages are tested with members of the staff, believe it or not, because they're available to easy interns, It's like us using student samples. And they say, okay, make believe that you are a poor Filipino woman, okay, and then tell me how you would respond to this, It doesn't,
I had a day off.
yeah. And then lack of methodological rigor and control, and mostly that's because of lack of sophistication. So best practices, and this is what I wanted to encourage them to do. Develop scalable evaluation plans. Even if you don't have much money, a little data collection is better than none at all. And as you do it, you can scale it up, especially if you start demonstrating that the data are useful and helpful in improving your product. You can use that as a way of persuading more support for doing evaluation research.
In terms of, I think, at least from what I know in healthcare work or intervention work that happens particularly in Nepal, there seems to be a lot of this, emphasis on what they call M&E, right, monitoring and evaluation. But really, it's only about the outcome evaluation, which always puzzles me because there isn't any discussion about the front end, the middle end, and all of a sudden, voila, we're supposed to show that this happened. And because my mom works in that area, there's always this push from the donor agency to show us a number, show that you did, but there's no money for making sure it was done correctly, all the points that you're talking about, right? There's no money for, is it working? Do we need to change anything? But no, you roll it out, you're supposed to roll it out and then show us the evidence. And there's, just, it's like this, how, right? Why
A lot of
would you
times it's
think that
motivated
it's
by
a-
legal issues and also worries about being sued. And they're usually looking for adverse events. Is somebody getting sick or somebody dying? How do we minimize that risk, rather than trying to figure out what it's doing and how can we improve that system? So I think what happens is there's kind of this superficial understanding of the evaluation process, and a lack of emphasis on really doing it in an in-depth and meaningful way.
Or that there is a connection or a progression, right, from beginning to the end, that if you want the end, everything has to work at the front and the middle also. But somehow we just want the whatever achievement that we're supposed to have, and that's always puzzles me in how it's the emphasis, right, in doing that.
And then also a lack of recognition that the systems need to change. A lot of times the donors don't want to change the system because that's expensive. So they basically want you to come up with data that shows what they're doing works.
Yeah, it's like I feel good, I spend my money well, kind of a.
Right. And if there's data that shows it's not working, we really don't want to hear it.
And we are not going to give you funds next time.
Yeah.
I use formative data to inform summative research so that, the formative research is really the heart of evaluation research, the needs analysis, the audience analysis, the message testing, the tracking data. But all of those data, every piece of that is then used later on to fuel your summative evaluation, basically as baseline data for comparison. So typically in the evaluation research I do, I come up with a set of measures, and I use the same measures at several points in time, including at the very end. And then that's all compared in kind of a pre-post analysis to make sure that we're making a difference. And so if you don't do a good job with formative data, you're not going to be able to do a good job with summative data. And as I mentioned, you have no idea how many times I'm invited by agencies and organizations to evaluate whether their systems work, and they've collected no baseline data. They've collected no formative data. They didn't do any audience analysis. And then they want me to demonstrate whether it worked or not. I said, well, all these other things, this is how I build that.
Historical trend data. Historical trend data.
Yeah, so what I end up doing is trying to kind of search for data that may have been laying fallow, about this audience, or some archival data about what they were doing, or do comparisons between this community and a comparison community. But it's been so much better and stronger if we have these data early on. So coming up with a good formative evaluation plan is really important, and it's important not just for refining, but also for determining whether it's working or not. Build-in feedback systems and measures, which I mentioned. I keep repeating that because it's amazing that people don't do that. That it's really easy to do, especially once you're designing, like it's any kind of online system. Even a telephone response that you have a line people can call, or a number they can call, or a website they can go to, or place they can send a postcard, or anything, just so you get some feedback. Identify and collect baseline data for comparisons. Conduct usability tests with representative users. Conduct in-depth, rich data audience analysis, which is basically a recognition that a lot of it is very simplistic. Do not over-rely on self-report data. Collaborate with key audience members. So best evaluation research, this I think is my last slide. Longitudinal multi-point data collection. Multi-methodological research designs that you triangulate. Unobtrusive evaluation measures using along with traditional measures. Communication and health outcomes variables that you measure. Data used to demonstrate progress and direct action. Cost-benefit analysis. controlled field experimental designs, user-centered design. All of these, I think, are the factors that need to be built into evaluation research to make it work really well. Oh, I guess I got one more. These are the goals I left them with. Identify best strategies for communicating health information to key audiences. Test communication strategies, programs, and tools. Refine and enhance communication programs to achieve their health promotion goals. Implement the best health communication practices. Discovery, development, delivery. I talked about
I've heard
this.
that before, I think.
I like that. Yeah, you've got all my tricks in here. Anyway. So I think that if they want to do health promotion, if they can build strong programs and use them on a regular basis, it'll help. But the truth of the matter is that most of the agencies, most of the healthcare systems, are really not doing much evaluation research. They don't recognize it's important. They haven't budgeted for it. They don't have the expertise. They don't have the inclination. Later on down the road, they'll want them to demonstrate where their work's at, and they'll be scrambling, come up with, they'll go survey people, say, do you like it? And they'll say, yeah, we liked it. They'll write it up and say, yay. If they didn't like it, they'll ask somebody else. Until they find somebody who says they liked it.
2 thumbs up.
But that's why I think that there's a great opportunity for you and me and for our students to work with these agencies. And I wonder about here in Singapore with the Health Promotion Board, if there might be some opportunities to maybe work with them on doing evaluation. I wonder what kind of evaluation research they're doing.
I think at the teaching level, actually we work with the health promotion board by incorporate their agenda into our modules. So in the past, we do help them to do some kind of more like formative research to help them understand better of the audiences. Because I think one area of research that health promotion will be interested in is the tertiary students' health, and then they really need the student like the ambassadors to help them understand better of that population, and so actually that fits very well into our course design. So in the past we did help them to do some topics to explore like healthy eating, smoking, mental wellness, that kind of project. But mostly, at the we do more formative research, especially the audience analysis. Yeah, but as for the summative research, I think they have their own research team. Yeah, so that part we didn't really have much chance to work with them.
And the health promotion board, actually it's by division, so there's the tertiary student, and then there's this, and then often sometimes it's by topic, so it's quite fragmented in many ways. And it seems like that they are also not having a conversation within each other, because they do about 60 health campaigns or something a year, but it's coming out from different groups.
That's not
And
uncommon. It's the same in the U.S. The work I do with CDC, they have all these different divisions, and they're all doing different things, and they don't know about each other. That's one of the amazing things, and when I do these workshops, is that we bring all these people together from different areas, and they start learning about each other. They say, "Oh my God, you do that? I do that too." You have that problem, and then they start sharing resources.
Somebody told me the other day from Health Promotion Board that the last director who was doing health communication was tasked to find a thread in all of these programs. And then the next sentence was, oh, there's a new person, and I thought, I wonder if there's a connection between him leaving and, this task of bring a common thread of all the campaigns HPB does, and then this person must have lost all the hair or something. I don't know if there's a connection, but the way she said it, I was just like, imagine just all these years of having multiple
And
facets
that's
and not having a
that they
conversation.
don't have summative research,
Yeah.
because based on whatever information they provide on the website, it looked like they mainly relied on those population statistics. So that doesn't, to me, that doesn't look like they really do some primary research on stuff. For example, if for example one team they are working on youth smoking behavior, mainly that just means that they draw the population statistics and then to indicate that, oh, okay, so between 2009 and 2012, the prevalence of daily smoking increase or decrease, but to me that doesn't look like a direct evaluation of whatever campaigns they are doing. So yeah, that's.
You know, I've been impressed as I travel around this campus about the huge medical and health infrastructure here. I mean, the big NUH hospital, and there's all these, the Institute for Dentistry, and you know, as I'm traveling on the bus, I'm checking out all these places, walking around. I wonder if there's some way of connecting with these different clinical activities. I'm sure there's a lot of health education, health promotion activities that they're doing.
Don't forget the Chinese traditional medicine that we went and visited, right?
Tell me about that. What was that?
There's a Chinese medicine. Actually, it's a like education board. They train the traditional Chinese practitioners. Like some is like licensed, some is like short courses for the citizens. And then they have a hospital. They have clinics in different districts. And I think you know more because you visit.
No, this was, we were interested, when Barbara Scharf was here, we were interested in sort of this alternative to the Western biomedical and how that might influence as well. I mean, that might be an unwritten story or an unreported story in Singapore. And so we went to the main sort of medical school, if you will, of traditional Chinese medicine. And we got to meet with them a bit and talk about how they trained and how they sort of saw themselves vis-a-vis Western medicine. You know, and we're here talking about all the connections and the threads between the Ministry of Health. And I think, you know, there's an opportunity for someone to be doing that story as well in Singapore, the sort of the alternative medicine.
I wonder what percentage of the people utilize different types of medicine.
That's a great question.
I did an interview survey. Like I do 30 interviews with Singaporeans of different ages. Like most of the elderly people, they like to go to the traditional medicine for the like flu or cold, minor sicknesses. Only if they have like serious problem, they will go to the hospital.
Like heart disease or something like that.
Of course, yeah, heart disease, that kind of diabetes, maybe they will go to the hospital. But some kind of like normal thing, they just go to the traditional Chinese medicines shop.
So think about adherence to medications, and you know how that might dovetail or conflict in terms of, you know, the use of these other. That's somebody out here ought to be doing.
So Leanne and I we did a study on that. There's how elderly women negotiate that space between biomedicine and TCM, the tensions, and how they view these tensions and how they negotiate that. And because we think, okay, if you do the demographics, right, and not educated, no income, cannot speak English, but it's quite amazing the strategies that they use. It's very clear cut in their mind when biomedicine, when TCM, but then the problems are, right, there isn't a conversation, right, they're making with the docs, they're making that decision on their own, that today this, tomorrow that, right, and then you think, oh, what about the medications, right? But then they will say, well, if I tell either of the physicians, they're not going to understand. They will say, stop going to the other one. So therefore, I will not, so there's no disclosure. So I will have a conversation with my friends, with my family, and I will
make the decision.
And make the decision myself. But it's very, very clear cut as to what it's used for and, for when and how they would use each of those things. And it's interesting, the other thing that's interesting is it's so cultural, right, TCM. But then if you think about the health insurance, if you think about the medical certificates, it's only biomedicine. If you want to take leave from work, if you want insurance coverage, it only happens at by Western hospitals. If you go to a TCM physician for this, none of that is covered.
How much time do you have here, Gary?
Well, we have about an hour and a half.
No, I mean in Singapore.
Oh, yeah, 31st.
You wanna visit the?
Yeah.
I would. I'd love to.
We should take it.
We should take him. They gave me acupuncture last time. I think maybe it's you this time.
Okay.
What do you think?
Yeah, I can.
Would you be interested?
Sure, I would be.
Yeah. But it's a little bit tight time because of Chinese New Year.
Yeah.
but I can.
At the end of the month.
Yes, but you know, Chinese is like is so important.
Preparing for it.
And
yeah.
I know
Okay.
that the principal is from China actually. He came from China, might be traveling, but I can send an email and see whether it's possible
Sure.
or not. Yeah. Yeah. Because you have 2 more weeks, right?
Right,
Yeah. I can see whether it's possible to arrange something.
good.
Gives a whole different meaning to complementary medicine, right? The integration that they view, but
Yeah.
not from a medical profession, but from a patient perspective. It's
Mhm.
integrated as it can be.
And I think that, you know, they rolled out the red carpet a little bit and they were quite happy that, how shall I say, we were giving them some attention in terms of, you know, thinking about these connections.
Do
And
they have an affiliation with, in US at all?
within US.
No,
I don't think
definitely
so.
no.
No,
I just know them by chance. But it's actually I've never met them, but I just.
because I wonder what, you know, the Western medical, people think of them and vice versa.
Actually, I have a question for Seville or Raman. You said that any Western hospital has traditional Chinese sections in it in Singapore? No.
It's quite
Because
separate.
compare in Hong Kong, because I come from Hong Kong, in Hong Kong we do have now, like I think it's like 5 years, only 5 years of time, like we have a traditional Chinese medicine clinic in the hospital. And some of the hospital has the whole building, which is TCM.
Mhm.
And then, but they do start to communicate with each other.
Right.
But having them in one space is probably the first step.
Could we, maybe, this is an idea, it's a bit of a brainstorm idea. You're edging for a dual appointment over in public health. And they need lots of speakers in their public health communication, right? Would it be, I think it would be cool if you got somebody from there to accompany Gary and whoever else on, maybe have a little bit of a summit, you know, just 2 or 3 people asking just that question, what do they think of each other? And just
And the
on an
outreach.
informal little, because last time we all, it was Mohan, myself, Barbara, you know, and this was the first sort of overture that I can understand from NUS, but maybe having somebody, you know, official from the medical side might answer some of those questions and maybe lead to something, I don't know.
There's been, you know, growing recognition in the US about, the validity and utility
Sure.
of non-Western medicine.
Mhm.
And there's a couple of institutes that are, NCI has their own complementary and alternative medicine
Right.
research branch. And they've been doing really interesting, and there's a lot of data now that demonstrates that a lot of the complementary strategies work, particularly for dealing with cancer side effects, nausea, fatigue, depression.
And hearing them talk, they weren't over the top really in terms of making these, I mean, I don't know what I was expecting in terms of them saying, oh, you know, we can cure cancer or anything like that. I think that they were very knowledgeable in terms of where they fit, or at least in their articulating where they fit in terms of Western biomedicine. So at least from their side we've heard, but I would love to hear from the other side, like you said, what the biomedicine.
It's also interesting, you know, because this School of Public Health only became a school a year ago. Until then, they were part of the medical outfit here, so it'd be interesting to see their take on that too, right? Because they.
What was your experience yesterday when you went there? How did they go to the School of Public Health?
It was great. I have never said communication so many times in 3 hours in my life, and stressed the importance of communication.
Who was there? Who did you talk to? Just students? Were there faculty?
There's one faculty who is coordinating this module, but the other person is from Health Promotion Board, but she's apparently been an adjunct in School of Public Health for a long time. So she does more like lifestyle and wellness prevention kind of a topic.
Bring her to the hospital.
Yeah.
So what kind of response did they have to you and to what you had to say?
Oh, they enjoyed it, I think, and they were yeah. They were. I mean, students don't know any better, right? It's the first time they. But I think for the faculty too, right? Because that there was a different perspective, I would say, because being in school in public health, I'm pretty sure, from my understanding, that the way that they look at health promotion or the way that we talk about communication, and as I was saying to you a few days ago about some of the. They particularly liked your continuum, by the way, I have to
good.
say, and how
Because
we
it
are
comes
part
out-
of
yeah.
everywhere in healthcare, and how that is so central to and fundamental, right? To we do, and she was just overjoyed by that aside, and then
I stole that from public health, because that's why they like it.
It's the same tribe. And by the way, let's not be sort of exclusive here. Is there a Tamil or a Sikh or a Malay equivalent to this traditional Chinese medicine that is established in Singapore?
Established, no, but informal, there is an informal one.
Informal.
Yeah. Like
Do you have the BOMOs here that they have
yeah,
in
the
Malaysia?
momos, and yeah, they do have like concoctions when you're especially when you're pregnant. Yeah, they have this
Jamu massage
like
and
jamu
all that,
massage and
yeah.
all that. Yeah, but not something which is not established as TCM, but it's more of a more community level rather than.
And then
institutionalized level.
for
TCM is
Indian
really
Filipino,
institutionalized.
because Ayurvedic kind of
Little India, you'll find all those mini clinics.
all the certificates and then
unofficial.
Yeah, it's quite
so its status is different from other types of alternative medicine because it's controlled by the government. The government have the act. The government have the board to really regulate everything. So it's highly institutionalized in a way different from other medical practices.
But I found when I was working in Malaysia, this is a while ago, that there was a lot of antagonism between the traditional Western medicine and the BOMOs. That they didn't like each other, they didn't trust each other. The BOMOs were afraid that their clients would not come to them anymore. They were discouraging them to go to the doctors. The doctors didn't like the BOMOs because they didn't approve of their treatments. So it was a bad situation. We were trying to get them to work together, and it took a lot of massaging and encouraging to even get them to sit down and talk with each other.
I think after our study and knowing that there's a tension between the Western and the traditional Chinese tradition, I was saying to Leanne one day that we should look at the Western trained physicians who are culturally rooted in TCM.
Who may have as earlier
Right.
gone to those as
Or gone to those, or raised in family where they're taught these things and then they become Western trained. How that
Sounds
changes, and so we
You
we
can
should
find-
talk about I don't know if doctors would be willing to talk to us, but I was really interested and intrigued by that because culturally it's so dominant. But then yet you tell your parents and your grandparents and their friends, don't go to the traditional practitioners, right? Use Western medicine, and I just find that quite interesting.
In fact, I was just discussing with Raman that BOMOs have quite a bad reputation, and I think Malays have to go through this state of confusion because as a Muslim, you're not supposed to go to a BOMO. It's irreligious to do it. But at the same time, it's so cultural that as a Malay, a lot of times, BOMOs are very much a representation of their health needs. So I'm not sure how they work out this.
Because BOMOs have this stigma that they deal with like other, as in outside religion, spirits and all that. So that's why they have a bad rep with that. So there's always a very bad reconciliation between like Muslims and the BOMOs. So that's why.
And that's strange. I didn't realize that because most of the women who were seeing the BOMOs were Muslim,
Yeah.
and they trusted them a lot, much more than they did the Western medicine.
how do they reconcile
But
that? That is a
these
great
Muslims going
communication
to
question.
madrasas,
Mhm.
that's
We're
nothing
talking
important.
about barriers, and others.
Were these women, because I think a lot of times when they go to the madrasas to get educated, that's where they might separate the BOMOs from themselves, or they might say, I'm not going to a BOMO anymore, because in the madrasas they get taught that, okay, these things are not something that should be part of the religion. So where did these women predominantly
These were
come
women that had breast cancer, and they didn't want to go to Western medicine, so they went to the BOMOs. And the BOMOs were basically giving them traditional strategies for dealing with the breast cancer. it was not helping very much, you know. I think they had them do some chanting and some dietary things and some burning incense. I'm not sure exactly what they do, but it was nothing medicinal. And then what happened, the breast cancer kept growing to a point where these women then had to go to Western medicine because the tumor was obvious. But it was late stage, and you know, this happened many times. So the Western breast cancer physicians we were working with were very frustrated that if only these women had come to them early on, that they could have given them better treatment. But by the time they came to them, by the time they left the BOMOs, it was too late for them to help, and all they could do was palliative care. So it was basically what we wanted to do was to get the BOMOs to refer these women to see Western medicine surgeons once they ascertained that they did have breast cancer, so they could get early response. And that was the intervention we came up with.
You know, and that brings up this, back to your presentation, you know, we're ending with evaluation research, and then, so you've got great research, and people still don't use it, you know, so have you talked about translational research, you know, very much, you know, this week in terms of, all right, we know that we have all of these great programs out there that aren't being used, and people are complaining that they don't have money to, you know, but they're always funding new studies, and they're not using the ones that, even some of that work that are on the shelf.
Well, I think that has a lot to do with the collaboration. You know, the researchers and the practitioners need to start working together. They need to start making those connections, getting out into the clinics and working with the health promotional experts and public health departments. That's the only way to get it to work, because the folks there don't really understand the data very well, don't really appreciate it. And then we really don't understand what they're doing very well either. But when we work together, I think we can really get a lot done.
Or in evaluation, you know, people end with an effectiveness trial rather than an efficacy trial, you know, in terms of how it's going to work, you know, with the next group of folks in the next community. You know, you test it in one community and you go, oh, it's effective, it stops this or that, and you assume it's going to work everywhere else, and it's like, you know, no, there needs to be some efficacy trials in terms of, you know, the adaptations and the different ways that people are going to use these things.
I think what happens more often than not in health promotion is that rather than building new programs for different audiences, they try and reinvent the same program, which I don't think is a bad idea, but I think they need to make sure that the reinvention reflects the unique needs of the different audience and setting. The idea that they can just take these things and stamp them around is really a bad one. Even replicating the same programs with the same audience over time doesn't seem to work very well.
Sure.